Okay, so children, let's start with chapter 29, which is bloodstream infections. In this chapter, we will include etiological agents of bloodstream infections, types of bloodstream infections, clinical manifestations, lab diagnosis, fever of unknown origin, and infections causing anemia. So, to start with, bloodstream infection, this refers to the presence of microorganisms in blood, which constitute one of the most serious situations among infectious diseases, as they are threat to every organ of the body. Microbial invasion of bloodstream can serve serious immediate consequences such as shock, multiple organ failure, and DIC, disseminated intravascular coagulopathies. Okay, so as we proceed, therefore, timely detection of the causative agents is one of the most important goals of microbiology laboratory. Okay, so terminologies: the suffix emia is derived from Greek word meaning blood and refers to the presence of any substance in blood. Bacteremia refers to the presence of bacteria in blood without any multiplication. Septicemia is a condition in which bacteria circulate and actively multiply in the bloodstream and may produce their products, which are toxins that cause harm to the host. Similarly, the presence of viruses and parasites and fungi in blood can be termed as viremia, parasitemia, and fungemia, respectively. So, the types of bacteremia. Bacteremia may be transient, continuous, or intermittent. Transient bacteremia, it may occur due to spontaneously or with minor events such as brushing teeth or chewing foods, instrumentation of contaminated mucosal site, and surgery involving a non-sterile site. These circumstances may also lead to septicemia, although normally the bacteria are cleared from the blood by the host immune mechanisms. Second is continuous bacteremia. Here, the organisms are released to the bloodstream at a fairly constant rate. It occurs in conditions such as septic shock, endocarditis, and other endovascular infections. Also, during early stage of certain infections, including enteric fever, brucellosis, and leptospirosis, Klebsiella also can be thought of as a continuous bacteremia. Intermittent bacteremia, in most of the infections, bacteria are released into the blood intermittently. Sequestered focus of infections such as undrained abscess, bacteria are released approximately 45 minutes before a febrile episode. Early course of meningitis, pneumonia, septic arthritis, and osteomyelitis. Okay. Now starting with etiological agents of BSI. Pathogens of all four major groups of microbes: bacteria, fungi, viruses, fungi, and parasites can cause bloodstream infections. Bacterial etiology: bacterial agents account for the majority of bloodstream infections. The common agents include causing primary bloodstream infection include typhoidal salmonella, brucella or spirochetes, leptospira borrelia. Hasek group of pathogens: viridans, streptococci, and rickettsia infect vascular endothelium. These agents are discussed in subsequent chapters of this section. However, there are various other bacterial agents which can primarily infect other sites and subsequently spill over to the bloodstream to cause secondary BSI. These include gram-positive cocci, examples staphylococci, beta-hemolytic streptococci, enterococci, and pneumococci. Okay, gram-negative cocci such as meningococci. Gram-positive bacilli, Bacillus anthracis and Listeria. Gram-negative bacilli, example E. coli, Klebsiella, Enterobacter. Non-fermenters, example Pseudomonas, Acinetobacter, Burkholderia, Stenotrophomonas, and Haemophilus, Aeromonas, etc. Anaerobes such as bacteroids. Okay, above agents are discussed under the primary system they infect. Example E. coli is discussed under UTI, diarrhea, etc. Viral etiology. Although many viruses do circulate in the peripheral blood at some stage of the disease and have viremic phase, the primary infection usually occurs in target organs. There are few viruses that preferentially infect blood cells, which can be considered as viral agents of bloodstream infections. Human immunodeficiency virus (HIV) and other human retroviruses attack CD4 T lymphocytes and macrophages. Agents of hemorrhagic fever such as dengue, chikungunya, Ebola, Marburg, Lassa, yellow fever, and other viruses they infect endothelial cells. VHF is discussed in chapters, and yellow fever. Okay, Epstein Barr virus invades lymphocyte. It causes infectious mononucleosis and various malignancies. Cytomegalovirus invades myocytes, polymorphonuclear cells, and lymphocyte. It causes hepatitis and congenital infections. Now, parasitic etiology. Parasites cause bloodstream infections are such as Plasmodium and Babesia. They infect RBCs. Parasites that may be found in the bloodstream before they migrate to other tissues or gonads. Example: Tachyzoids of Toxoplasma gondii and amastigote forms of Leishmania and trypomastigore forms of trypanosoma. Parasites that may be present in the lymphatics and come to bloodstream transiently, example microfilariae or filarial parasites. Note that schistosoma or blood fluke reside in the venous plexus of the bladder and the intestine. However, the clinical manifestations are principally confined to the bladder and intestine and therefore have been discussed in chapters. Tagozoids of Toxoplasma gondii also appear in blood. However, it is principally caused CNS and congenital infections. Starting with fungal etiology, fungemia is the presence of fungi in the blood, usually serious condition occurring primarily in immunosuppressed patients, patients with malignancies, patients on chemotherapy, and those with serious or terminal illness. All right. So Candida species, these are the most common etiological agents of fungemia. They account for 8 to 10% of all nosocomial bloodstream infections, both Candida albicans and non-albicans. Candida species such as Candida tropicalis, Candida paralisosis, and Candida auris can cause bloodstream infections. Agents of systemic mycosis, histoplasma, blastomyces, coccidioides, and paracoccidioides can also invade bloodstream. These infections usually begin as pneumonia and then the fungi may disseminate from the lungs to the bloodstream, from where they seed into the other organs. Cryptococcus predominantly causes meningitis, although fungemia is also observed. As bacterial agents are the most common group to cause bloodstream infections, therefore the rest of the discussion of this chapter is largely limited to bacterial agents. The viral, parasitic, and fungal agents will be discussed in detail in the subsequent chapters. Types of bloodstream infections. There are two major categories of bloodstream infections, intravascular and extravascular. Factors that contribute to the initiation of BSI are immunosuppression. Use of broad spectrum antimicrobial agents can suppress the normal flora, thus allowing the emergence of resistant strains of bacteria. Invasive procedures or extensive surgeries that allow the bacteria to access the blood. Prolonged survival of debilitated patients. Okay. Starting with intravascular bloodstream infections. They originate within the cardiovascular system, which includes infection of the heart, endocarditis, myocarditis, and pericarditis, and catheter-related BSI, which is the CRIPSI. Okay. Extravascular bloodstream infections. Most cases of clinically significant bacteremia are of the extravascular origin. The organisms multiply at the primary site, such as lungs, and are drained by lymphatics and reach the bloodstream. Okay. Now, the organisms are either removed by the cells of the reticuloendothelial cell system or they multiply more widely and thereby causing septicemia. The portal of entry, most common portals of entry for bacteremia are genitourinary tract 25%, followed by respiratory tract 20%, abscess 10%, surgical site wound infections 5%, biliary tract 5%. In up to 25% of the cases, the portal of entry remains uncertain. Agents, the bacteria invading the bloodstream depend on the portal of entry and have been listed in the table. Now, the clinical manifestations, bloodstream infections have a bacteremia stage followed by septicemic stage. Okay, the clinical manifestations are evident only in septicemic stage. In this stage, the bacteria multiply and release the products or toxin which travels to various organs affecting their functions. Based on the severity and extent of the organ failure, organ system infection can be divided into two stages, sepsis and septic shock, that we will discuss in the table. Sepsis is the common signs and symptoms of sepsis include fever or hypothermia with or without chills and rigor. Hyperventilation leads to excess loss of CO2 and subsequent respiratory alkalosis. Skin lesions, change of mental status, and diarrhea. Septic shock. This is the gravest last stage complication of septicemia and is manifested as hypotension. Okay, and TIC, multi-organ failure, etc. Example, acute respiratory distress, renal failure, tissue destruction, etc. The endotoxin of gram-negative bacteria have direct effect on the pathogenesis of septic or endotoxic shock. In sepsis, the severity and degree of organ failure can be determined by an assessment score called SOFA, Sepsis Related Organ Failure Assessment, and Quick SOFA criteria table 29.2. So let's discuss these tables. Starting with 29.1, bacteria causing extravascular bloodstream infections and their common sources. So E. coli and other gram-negative bacteria such as Klebsiella, Proteus, Enterobacter, Pseudomonas, they enter through urinary tract or intestine rarely. Haemophilus influenzae type B, meninges, epiglottis, and lungs. Pneumococcus enters through meninges and lungs. Brucella enters through reticuloendothelial system. Salmonella typhi enters through small intestine, lymph nodes, and reticular endothelial system. Listeria enters through intestine, meninges. Staphylococcus aureus and coagulase negative staphylococci enter through surgical site infections. Now coming to 9.2, definition of sepsis and the assessment of severity on organ failure. Sepsis is defined as life-threatening organ dysfunction caused by dysregulated host response to infection. SOFA score. Sepsis is diagnosed by SOFA sepsis-related organ failure assessment score, which in turn depends on 6 parameters: respiratory system, PaO2 upon FiO2, coagulation system, platelet count, liver, serum bilirubin. Fourth, cardiovascular, mean arterial pressure (MAP). Fifth, central nervous system Glasgow Coma Scale score. Sixth, renal, serum creatinine and urine output. Organ dysfunction can be identified as an acute change in the total SOFA score more than equal to 2 points following the infection. Q-SOFA or the quick SOFA criteria. Determination of the SOFA score takes considerable time as it depends on a number of laboratory parameters. However, before the result of SOFA score is available, sepsis can promptly be defined at the bedside with Q quick SOFA score, like respiratory rate more than equal to 22 per minute, altered mentation, systolic blood pressure less than equal to 100 mmHg. Now the septic shock. It is a subset of sepsis in which underlying circulatory and cellular metabolic abnormalities are profound. Patient with septic shock can be identified with a clinical construct of sepsis with persisting hypertension requiring vasopressors to maintain MAP, mean arterial pressure more than equal to 65 mmHg, and serum lactate level more than 2 millimole per liter, 18 mg per deciliter, despite adequate volume resuscitation. Patients with septic shock have a mortality of more than equal to 40% in contrast to 10% for sepsis cases. Note, PaO2 upon FiO2 is the ratio of arterial oxygen partial pressure to the fractional inspired oxygen. Okay, so now let's come on to laboratory diagnosis. So laboratory diagnosis of bloodstream infection depends on the isolation of the causative agent from the blood by performing blood culture. The specimen collection and blood culture starts with extreme care should be taken while collection of the blood for the culture as there is high risk of contamination with the skin flora. Site blood for the culture should always be collected in pairs from two separate venipuncture and two separate skin decontamination processes. If a central line is present, then one sample from the central line and one from the venipuncture should be collected. First is preparation of the site. To avoid contamination with the skin flora, blood should be collected under strict aseptic conditions using sterile disposable syringes, such as shown in the figure. We'll see it. Okay. Now, skin decontamination. Skin should be disinfected by two-step procedure. First, treated with 70% isopropyl alcohol, and then second, antiseptic solutions such as povidone, iodine, or chlorhexidine should be applied. The disinfectant should be applied in a circular motion 5 cm in diameter starting from the center to the periphery. The area should be allowed to air dry before venipuncture. Timing of collection. Blood should be collected before the starting antimicrobial therapy. If the antimicrobial agent is already started, then the best time of collection is just before the next dose of antimicrobial agent. Blood volume. Blood specimen is drawn using a sterile syringe and needle. The higher the volume of blood, greater is the chance of isolation. Yield increases by 3.2% per ml of blood culture. At least 8 to 10 ml of the blood per bottle for an adult and 1 to 3 ml per pediatric bottle is recommended. Okay. Now, number of blood culture, at least 2 to 3 blood culture sets. Each set consists of 2 bottles, one aerobic and one anaerobic are required to have good isolation rate around 65%, 80%, 95% with 1, 2 and 3 sets respectively. Multiple blood culture should be collected for endocarditis cases. Dispensing. Collected blood is then directly dispensed into the blood culture bottle at the bedside, either a conventional or automated blood culture bottles. Alright. Change of the needle between collection and dispensing and old practice is no longer recommended. Transport and blood specimen. The collected blood is gently mixed with the broth and then transported immediately to the microbiology laboratory. In case of delay, blood culture should never be refrigerated. It can be kept at 35 degrees Celsius in an incubator if available, or left at room temperature. So in the steps of collection of blood culture, first is perform hand hygiene and use sterile gloves. Then apply tourniquet, palpate the vein and mark the area. Step 3, use 70% alcohol to disinfect the site upside down. Wait for 30 seconds. Allow the skin to dry. Step 4. Use chlorhexidine, povidone, iodine to disinfect the site. Concentric inside out. Wait for 1 minute. Allow the skin to dry. Step 5. Alcohol wipe to clean the bottle top. Step 6. Collect blood aseptically and inject into the blood culture bottle without changing the needle. Now, conventional culture medium. The method of the conventional culture is as follows. Types of media. There are two types of conventional culture media: monophasic medium and Castenda's biphasic medium. Monophasic medium consists 50 to 100 ml of blood of brain heart infusion BHI broth, and Castenda's biphasic medium consists of BHI agar slope and BHI broth 50 ml. Dilution. Dilution: blood is inoculated in the medium at a dilution of 1 is to 5 so that antimicrobial antibacterial components in the blood, if any, will get diluted. Okay. Now, SPS, sodium polyanethol sulfonate, is added to the medium as an anticoagulant. It also counteracts the bactericidal action of the blood. Incubation: upon receipt, the bottle should be directly incubated in the upright positions at 37 degrees Celsius for up to 7 days. Repeat subcultures are made from the BHI broth onto the blood agar and McConkey agar. From monophasic medium, subcultures are made when the broth becomes turbid or periodically blind subcultures for 1 week. There is a risk of contamination due to opening of the cap of the bottle every time when subcultures are done. In biphasic medium, the subcultures can be made by tilting the bottle so that the broth runs over the agar slope. There is lower risk of contamination as it obviates the opening of the cap of the bottle. The colonies appear over the agar gland, which is further used for identification. So in figure 29 to C, blood culture bottles, monophasic medium BHI broth is in A, biphasic medium Castendas is in B and containing BHI broth and BHI agar gland. And in C we have backed or alert bottle. All right. Now we have automated culture media. So what has this? Backtech and Bacti or Alert are automated blood culture systems. The most advanced system is Bact or Alert Wire 2O. In these systems, the growth is continuously monitored and reading is recorded every 15 to 20 minutes. Alright. When the growth is detected, the system gives a positive signal, then the bottle is removed and processed, similarly as done for conventional bottles. Automated systems are much more superior to conventional media in terms of faster isolation and increased sensitivity. More so, they also help in diagnosing catheter-related bloodstream infection quickly by determining the differential time to positify. Okay. Now, identification isolation organism is identified by colony morphology, gram staining, followed by either conventional biochemical reactions or automated infections identification system such as Malditov or Vitek. Antimicrobial susceptibility test is carried out for guiding the institution of appropriate therapy. Minimum inhibitory concentration MIC is based method. Example: Vitek is preferred over this diffusion method where testing for blood isolates. It is ideal for endocarditis isolates, especially while reporting AST result of penicillin. Treatment: due to the higher prevalence of multi-drug bacteria and higher mortality in sepsis, antibiotics should be instituted at the earliest as soon as the sepsis is clinically suspected. De-escalation approach is usually followed, which means empirical treatment consists of higher class of antimicrobials with both gram-negative and gram-positive coverage. Example: carbamazepine, such as meropenem plus vancomycin. Definitive treatment can be tailored according to the culture sensitivity report. Okay, so now we start with fever of unknown origin, FUO. Fever of unknown origin, FUO, is a very common term used by clinicians to refer to any febrile illness without an initial obvious etiology. Most febrile illnesses either resolve before a diagnosis can be made or eventually show typical clinical features or positive for specific investigation that lead to arrive at a correct diagnosis. These group of febrile illnesses are not called as FUO. The term FUO is reserved only for prolonged febrile illness without an established etiology despite of intensive evaluation and diagnostic testing. Definitions: with the advent of modern diagnostic tools, the definition of FUO has changed over time. Petersdorf and Beeson have defined fever of unknown origin in 1961 as patients having temperatures more than 38.3 degrees Celsius, more than 101 degree Fahrenheit at least on 2 occasions, for a duration of more than 3 weeks, failure to reach a diagnosis despite 1 week of inpatient investigation. This traditional definition was modified over time to time. In recent days, patients with FUO undergo various investigations in outpatient department and are hospitalized only if their clinical condition warrants. Thus, the inpatient evaluation requirement has been eliminated from the definition. As an immunocompromised patient, the diagnostic workup requires an entirely different and extensive list of investigations. They were excluded from the FUO definition. The diagnostic workup investigation criteria has been changed from quantitative criterion diagnosis uncertain after 1 week of evaluation to qualitative criterion, which requires the performance of a specific test of investigation before labeling as a case of FUO. This will help the optimal comparison of patients with FUO from different geographical areas. The current definition of FUO, accordingly, FUO is defined as follows: fever more than 38.3 degrees Celsius, 101 degree Fahrenheit at least 2 occasions, duration of illness more than 3 weeks, no known immunocompromised state, diagnosis that remains uncertain after a thorough history taking, physical examination, and the following obligatory investigations: ESR and CRP levels, platelet count, leukocyte count, total and differential, and hemoglobin, electrolytes, creatine, total protein, ferritin, and protein electrophoresis, enzymes such as alkaline phosphatase, alanine aminotransferase, aspartate aminotransferase, lactate dehydrogenase, creatine kinase, antinuclear antibodies, and rheumatoid factor, culture, blood culture, 3 negative cultures, and urine culture, radiology, chest X-ray, abdominal USG, tuberculin skin test, or interferon gamma release assay. Etiology of FUO. FUO has both infectious and non-infectious etiology. Infectious 36%. This accounts for the majority of FUO cases. All groups of microbial infections, both localized and systemic, can cause FUO, as we will see in the table. Neoplasm 19%, for example, lymphoma, leukemia, myeloma, renal, colon, and liver cancer, etc. Non-infectious diseases, non-infectious inflammatory diseases 19%, for example, connective tissue disorders like rheumatoid arthritis, SLE, systemic lupus erythematosus, etc. Miscellaneous causes 19%, granulomatosis diseases, inherited and metabolic diseases, thermoregulatory disorders, undiagnosed cases 7%. Laboratory diagnosis. Specimen collection. Prior to the specimen collection, a complete clinical history including details of travel, immunization, exposure to any other patients, and physical examination should be carried out. That may be helpful in choosing the appropriate specimens such as blood, urine, bone marrow, aspirate, pus from abscess, etc. Then microscopy. Blood microscopy is useful for detection of malaria parasite. Example: ring forms of gametocytes, filarial nematodes, microfilarial leishmania, donomani, LD bodies, or amastigote forms, toxoplasma, tachyzoites, and trypanosomas, trypomastigote forms. Stool wet mount for the detection of cyst, trophobocyte, or ova of a parasitic agent causing FUO, and Amoeba histolytica. Gram stain of pus, sputum, and other specimen can be carried out for detection of causative agent. Zeal nasal stain for Mycobacterium tuberculosis, periodic acid shift pass, or Komori methanamine silver GMS stain for detection of fungal morphology. In culture, what do we see? Blood culture is done for typhoid fever, brucellosis. Culture on low stain Jensen medium is done for Mycobacterium tuberculosis. Okay. Culture of pus and extruate specimen from the abscess for detection of causative agent. Saborod dextrose sugar SDA culture for fungal isolation. Cell line cultures. Culture in appropriate cell lines is useful for isolation of viruses. Example: human diploid cell line for cytomegalovirus. Now in serological tests, ELISA and rapid tests for viral diseases such as hepatitis B and C, HIV, CMV, EBV infections, etc. Standard agglutination test is for brucellosis. Is microscopic agglutination test for leptospirosis, cold agglutination test for mycoplasma, Bill Felix test for rickettsial diseases, Paul Bunel test for infectious mononucleosis, Vidal test for typhoid fever, microimmune fluorescence test for chlamydial infections, rheumatoid arthritis factor for rheumatoid arthritis, antinuclear antibody detection by immunofluorescence or ELISA for diagnosis of SLE. In this table, we can see bacterial and non-bacterial causes. Like bacterial causes have localized pathogenic infections like appendicitis, cholangitis, cholecystitis, localized abscess, mesenteric lymphadenitis, osteomyelitis, pelvic inflammatory disease, sinusitis, suppurative thrombophlebitis, and intravascular infections. Okay, systemic bacterial infection like mycobacterial infection, typhoid infection, rickettsial infection, mycoplasma infection, chlamydial infection, brucellosis, melioidosis, listeriosis, bartonellosis, actinomycosis, and nocardosis, spirochete infection, syphilis, Lyme disease, lapsing fever, leptospirosis. Non-bacterial causes can be viral infection, parasitic and fungal. So viral infection like cytomegalovirus and EBV infection, coccidiovirus group B infection, viral hepatitis, HIV infection, HSV infection, dengue, West Nile virus infection, Colorado tick fever, hantavirus infection, parvovirus infection. Parasitic infections like malaria, amoebiasis, leishmaniasis, Chagas disease, toxoplasmosis, strongyloidiasis, echinococcus, schistosomiasis, and toxocariasis. Fungal infection like aspergillosis, mucormycosis, blastomycosis, histoplasmosis, coccidiomycosis, paracoccidiomycosis, candidiasis, cryptococcosis, pneumocystis infection, and spirotrichosis. Okay, so now we had talked about the factors. Now we have molecular test. If the infective organism load is very low, PCR can be very useful as it amplifies the specific gene. Multiplex PCR can be carried out, which can simultaneously detect the common etiological agents of bloodstream infections. Okay. Now other agents we have like complete blood count, increased neutrophil count indicates pyogenic infections, increased ESR. Okay, or it also indicates uh, erythrocyte segmentation, the histopathological examination of the biopsies obtained from the uh, tumor may suggest the underlying etiology, and imaging methods, chest X-ray for diagnosis of tuberculosis, and CT or MRI scan to identify the malignant tumors and their extension. ECG and electrocardiography for rheumatic fever and infective endocarditis. Okay. Now we have the last topic of the chapter, which is infections causing anemia. Anemia refers to decrease in total amount of red blood cells of the hemoglobin in the blood or lowered ability of the blood to carry oxygen. It may occur due to several etiologies. Okay, the infective causes are listed in the table, like iron deficiency anemia. It occurs due to the blood loss, which occurs as a result of infection with various agents, leading to microcytic hypertrophic anemia, like hookworm, Nectata americanus, or Encyclostoma duodenal, Trichius trichuria, and Schistosomia species. All right. Now we have hemolytic anemia, which occurs by destruction of RBCs, by malaria, Plasmodium falciparum, Babesia microti, Bartonella bacilliforms, Clostridial sepsis, Clostridium perfringens, Mycoplasma pneumoniae, infectious micronucleosis like EBV, Epstein-Barr virus, and hepatitis A virus. Megaloblastic anemia can be caused by parasite Diphyllobotium lactum. It is caused by dissociation of vitamin B12 intrinsic factor complex within the gut lumen, which leads to decreased absorption of vitamin B12 in the ileum. And lastly, we have aplastic anemia, which occurs as a result of bone marrow dysfunction or failure, leading to a normocytic normochromic type of anemia. This can occur due to infection of the following agents like Mycobacterium tuberculosis, rickettsial infection, Leishmania donovani, cytomegalovirus, Epstein-Barr virus, Varicella zoster virus, parvovirus B90, aplastic crisis in patients with chronic hemolytic anemia, human immunodeficiency virus HIV, human herpes virus HHV6, hepatitis C virus, and dengue virus really. Okay. So now lastly we have some questions like a 40-year-old female patient presented with fever, chills and rigors, confusion, anxiety, difficulty in breathing, mild eyes and vomiting. Okay. On examination, the following signs were noticed: body temperature, heart in output. So what can be the clinical diagnosis? So we can say, and what are the scoring systems? So like we have this, the patient is in shock. He's in a shock with the bloodstream infection. So we can use these so far scores and in the answers. And what scoring system about the how you collect the specimen and the lab diagnosis we can write in detail. Second question says a 28-year-old male is presented with elevated temperatures 102 degree Fahrenheit for more than 3 weeks. The patient is hospitalized for the past 5 days without elucidation of a cause. So what's the probable diagnosis? It's a fever of unknown origin. So we can list the various etiological agents also, and we can like write the approach for the lab diagnosis as well. Okay. So this completes our chapter bloodstream infections, including infections causing the anemia. Okay, thanks for watching. Like, share, subscribe.